All right, it is 12 o'clock, so why don't we go ahead and get started. I want to welcome everyone to Medical Grand Rounds here at the University of Colorado. Happy to be back here in person, Krugman Conference Hall, the second floor of RC2. So if you're watching this on Zoom, please feel free to come back in person, although I can say we are almost out of seats, so we're doing all right. Upcoming talks, a little teaser for the weeks to come. Next week, we have Dr. Rita Lee and Dr. Chris Katsani will talk and co-present on gender-affirming care. And the week following that will be Dr. Tim Lamb from National Jewish, who will be speaking about gender differences in pulmonary hypertension. As a reminder, you can use this code to get CME and MOC credit for all grand rounds this year. Primarily, questions will come live from the audience, but our chief medical residents, thank you to the chiefs, will be here to take questions from the Zoom Q&A function. So please use that if you have questions for Dr. Blaha. But before we get to introduce Michael, I want to have Dr. Brian Haugen come up and speak to us a minute. Dr. Brian Haugen is, of course, our division director for endocrine, and talk about the Robert Eckel lecture series.
Thank you, Jeff. Sorry, Bob and Margaret, I got to do this again, but this is important. We just did this at the Endocrine Grand Rounds this morning, and really it is a thrill for me to this is the inaugural Robert H. Eckel Endowed Lectureship in Cardiometabolic Medicine. And what's really cool about something like this is we actually have Dr. Eckel right here with us. So, it's not a memorial, as Dr. Eckel says. And really, this kind of honors two things. One is this is something that Bob and Margaret Eckel, and Margaret's here too, generously gave support for this endowed professorship. So we can now have a yearly annual lectureship by experts around the country and in the world in cardiometabolic medicine. And so, that really is a neat legacy that they've done for us. But also, this really does honor Bob, who, for those of you who don't know Bob all that well, I think many people do, he actually came here and joined the faculty in 1979. And I first met him in 1988 when I was a resident, and he was my attending on medicine inpatient. And Bob is the reason I went into endocrinology. And also, one thing I didn't say this morning, he's the reason I think I'm a physician scientist as well. He's one of the people that really pushed me for that passion in science and medicine and trying to help our patients. So I really owe a lot to Bob. So this is especially nice for me to be able to do this. So Bob has expertise across the board, but especially in lipids, obesity. He's done translational medicine, and especially around lipoprotein lipase, which he's done some of the seminal work in the peripheral actions and then in the brain, which has led actually to people who have come out of his own group who are now independent investigators like Dr. Kim Bruce. So this is really neat to do this for Bob. And on top of everything, he's really a fantastic mentor. And he's mentored so many of us, and so many of us are in the field and doing what we're doing because of Bob. So I just wanted to acknowledge Bob and Margaret for their generosity in setting this up. So I'll turn it back over to Dr. Connors.
Dr. Eckel, thank you from me as well. And now it really is my pleasure to introduce Dr. Michael Blaha. He is a professor of cardiology and epidemiology, is the director of the clinical research and director of the cardiometabolic clinic for the Johns Hopkins Center for the Prevention of Cardiovascular Disease. He did his undergraduate training at Notre Dame, where he was a nominee for valedictorian. His medical school was then done at Vanderbilt, where he was elected AOA and was president of AOA, also winning several prestigious awards upon graduation. He then became a resident at Johns Hopkins Hospital, where he also did his fellowship training, and he has advanced training with MPH that he got while he was still at Vanderbilt. Dr. Blaha, very impressively, has published over 550 scientific articles with a focus on the appropriate use of tests and new therapies in the prevention of atherosclerotic cardiovascular disease. He's received multiple grant awards from the NIH, the FDA, the American Heart Association, the Amgen Foundation, Aetna Foundation, Bayer, and Novo Nordisk. He is a standing member of the Endocrinologic and Metabolic Drug Advisory Committee for the FDA. In 2018, Dr. Blaha received the Fred Roncati Award at Johns Hopkins for excellence in mentoring for his work in mentoring over 30 other young scientists, many of whom have received significant academic appointments in the wake of his mentoring. He was also named the Clarivate Highly Cited Researcher List for being among the world's top 1% of published researchers. Clinically, he is a practicing cardiologist, preventive cardiologist, specializing in cardiometabolic disease and the interpretation of cardiac CT. His clinic specializes in patients with cardiometabolic disease and advanced subclinical atherosclerosis, and is focused on the use of lifestyle modification as well as pharmacotherapies to mitigate that risk. And I know that you got a similar introduction at endocrine grand rounds this morning, and so maybe I'll add a little bit of a personal note. So we did have a chance to overlap as fellows in Baltimore, which means two things. One, I can do the math on his 550 publications. That is 4 per month, every month, including during the pandemic since he graduated in 2009. No small feat. And I can also let you know that he is a wonderful human, thought of as a very kind, very generous, and a really wonderful clinician, in addition to all of his academic accomplishments. So it really is a privilege to welcome Mike Blaha.
Thank you so much. So this is, I'm going to repeat a few things from this morning, but it was such an honor to be here for the Bob Eckel lectureship. Bob is one of the greatest people I've met in the field, and I've been a mentor to me, and I idol and then a mentor, then a friend, which is the evolution of the relationship, which has been great. And I really appreciate the introduction as well, because it hits on several of the things that we'll talk about today. I am a preventive cardiologist. I also practice what I would call cardiometabolic medicine, which we'll talk about today, which I think is the reason, of course, I'm here for the Bob Eckel lectureship. So anyway, indeed, our prevention center at Johns Hopkins is a broadly interpreted preventive cardiology center, of which there is a clinic within the prevention center called the cardiometabolic clinic, which I direct. So a lot of this will be with direct relevance to how I practice every day as a preventive cardiologist, specifically in our cardiometabolic clinic. Okay, so the title of this talk is Evaluating and Treating Residual Risk in Atherosclerotic Cardiovascular Disease. So this term is thrown around a lot, residual risk. In fact, people use it in different areas of medicine, but it's specifically used a lot in atherosclerotic cardiovascular disease. So I thought we'd drive down and figure out what it is that we mean by this. And then throughout the rest of the talk, we're going to play with this term and figure out what do we really mean by residual risk. But of course, if you look up residual risk in the dictionary or in online, it says the risk that remains after efforts to identify and eliminate some or all types of risk have been made. And the residual risk is, of course, that risk that's left over after some improvements have been made, in this case, to clinical care. So we can imagine it looks like this. There's lots of inherent risks of, let's say, atherosclerotic cardiovascular disease. We can do some things to prevent that risk, but there's always going to be risk that remains. And we know that to be true. So an example, if you look this up, is, for example, like a seatbelt. So if you're driving your car, there's obviously some inherent risk of an injury. If you wear a seatbelt, that risk goes down, but there's still residual risk, of course. So what we're going to be dwelling on a lot in this talk is, what are these controls? What are these things that determine what is residual to that in terms of risk, right? So we have risk of atherosclerotic cardiovascular disease. We're going to apply the seatbelt, whatever it is that's sort of standard of care, I suppose. And then afterwards, what's left is residual risk, and we'll try to analyze that. So we're going to think about that as we go through this lecture. And then hopefully at the end, I'm going to challenge us to rethink what we mean by residual risk, or what is it residual to. So most of the time in atherosclerotic cardiovascular disease, when we talk about residual risk, we talk about residual to statins. That's sort of the general understanding of the term. And here's the kind of the basic slide that's shown most of the time when we talk about residual risk, which is that even in the main statin trials, running from these high-risk trials to lower-risk trials, even after statins are used and the risk comes down, there's still a number of people in the statin treatment group that get recurrent events, right? This makes sense. That's some component of residual risk. Now, of course, these are only patients that have been on statins for a few years. So another thing that challenges us when we think about residual risk is not just the intervention, but the timing of the intervention too. Because we know that if you have a genetically lower LDL cholesterol for life, you have a much lower risk than if you lower that LDL much later in life with, let's say, a therapy. So what we're showing here is the relationship of LDL to residual, or to risk from SNPs that basically determine lower LDL from birth or from pharmacological therapy. And we see a much stronger relative risk reduction with the lower cholesterol if it was present from birth. So that's the start of the challenging of the term residual risk. Residual to what? If it's residual to statin, residual to how long have you been on a statin, for example? Okay, so let's talk about how mechanism determines our thoughts about residual risk, and then how it determines our approach to treating patients. So the most common slide that's shown nowadays when it comes to residual risk is this one, and I'll spend a little time on this. So it shows patients at high risk for ASCVD at the top. It says after some contemporary therapy, usually a statin, then we're going to assess what residual risk the patient has. And these are the categories that are commonly used. So it's interesting. The first thing I want to point out here is you'll see that it's divided into distinct categories as if we can separate them so easily, right? Residual cholesterol risk, residual inflammatory risk, residual thrombotic risk, residual triglyceride risk is what it's shown here, residual lipoprotein A risk, and then here, residual diabetes risk. And the great thing about the field right now in preventive cardiology is we have great innovations in most of these areas. You can see here at the bottom the randomized trials that have been that are ongoing or completed in each of these areas. We're starting to show that lowering LDL or attacking inflammation, adding on low dose antithrombotics, potentially lowering triglycerides, all can potentially have a benefit on cardiovascular disease. But where this gets tricky is how distinct really are these categories, and can we think about this in a more fundamental way? So let's do this. Let's go through a case. You guys want to start with a case? I know it's a Hopkins tradition to do a case. I think you guys like to have a case too, but this is going to challenge us to think about residual risk. Okay, so let's assess the categories of residual risk in this patient. This is a patient that we all could see any day in medicine or in cardiology. A 64-year-old man, he's a truck driver, has a past medical history of hypertension, type 2 diabetes, and he had an anti-RMI 4 years ago with some stents, additional stents that were needed 3 years ago. So he's got established atherosclerotic cardiovascular disease. His BMI is 34, class 1 obesity. His blood pressure remains above our goal. His left ventricular ejection fraction is a little low. His hemoglobin A1C is 8.2%. His LDL is 75. His HDL is low. His triglycerides are high. His Lp(a) is high. He's just developed early stage 3A chronic kidney disease. He's got a little microalbuminuria. His CRP, if you were to measure that, is elevated too. And he's a former smoker that drinks a little bit and only gets about 6,000 steps a day with no dedicated exercise. And currently he's on an aspirin, a statin, a beta blocker, and metformin. So maybe based on the slide I just showed, you're going to start to think about what categories of residual risk this patient has. And I would argue he has most of the ones that I showed, right? There's many different ways of approaching this patient in terms of lowering the risk further. So what types of residual risk are present in this patient? Well, there's residual lifestyle risk, right? He could improve his lifestyle. He certainly needs to do that. There's residual so-called cholesterol risk. His LDL was above where we'd like it to be in our current guidelines. In fact, this patient, based on the new expert consensus decision pathway, should have an LDL less than 55. There's residual triglyceride risk. His triglycerides were above 200. He's got a high Lp(a), which confers residual risk. He's also obese. And he also has diabetes. He's got a low ejection fraction. It's in the mid-range. He's at risk for heart failure with at least relatively preserved ejection fraction. He's also developing kidney disease, so he's got residual kidney risk. He's got residual thrombotic risk and residual inflammatory risk based on a high CRP. And you can see I've listed kind of the different interventions that would all be associated with these types of residual risk, right? Everything from intensive lifestyle interventions, a series of LDL lowering therapies we could give, triglyceride lowering therapies, PCSK9 inhibition can lower Lp(a) a bit, but on the way are antisense oligonucleotides for lowering Lp(a). We'll know the results next year, and down the list, including antibodies to different pathways like IL-6 in terms of anti-inflammatory therapies that are coming. So very soon we're going to have so many options for a patient like this. And how do we proceed? Well, it's tricky, right? Because we did this analysis. We actually used the Copenhagen heart study to do this analysis because we wanted a very large population of patients who've had a history of MI. We said, well, just based on clinical trial criteria that were published at this time, how many patients with established ischemic heart disease would be eligible for at least one additional expensive cardiovascular therapy for secondary prevention? If you see here, the answer is most patients, you go patients with prior MI, almost all of them are eligible for at least one additional expensive therapy. 80% would be more than the 2 drug classes, and another 80%, at least 4 additional classes of drugs, if I go down those lists. So So how is it that we're going to decide how we're going to treat this patient, right? What we concluded from this this study, we said raises questions for the cardiovascular community about access to these potentially expensive medications, including strategies for prioritizing their use. Because if you look at cardiology guidelines, they're very commonly risk factor based, just like I showed you before. We could look at the blood pressure guidelines and figure out what to do. We could look at the cholesterol guidelines. We could look at diabetes guidelines. And it's very unclear about how we should be prioritizing the therapies. They recommend treatment based on individual risk factors. They provide very little guidance in the order of therapies that they should be applied or the priority of which they should be taken. I'll give you what my first thesis for this talk is. Here's my first thesis for the talk. I think most physicians, at least at the current time, are willing to prescribe one or two very expensive drugs to their patients, but not a lot more. I think that this is where we're at right now. We're in a situation where we have to be considering value of care. I could think of a way to spend $100,000 on this patient, or I could think of very inexpensive ways of approaching this patient too. And it's very unclear, which one we should do. So let's come back to Joseph's medical care here. What I would argue is that the perspective on this patient for everyone in this room depends incredibly on your background. Are you a nephrologist? Are you a cardiologist? You're an endocrinologist? On your training, maybe where you trained, maybe what you're interested in. I sort of interested in LDL, so I think about LDL. And also your tolerance of cost and hassle, right? Your tolerance of going through the process of pre-authorizations or getting access to the patients. So basically, we're in a situation now where we're very heterogeneous care of this patient, right? This patient could be offered anything from a couple additional generic therapies, lifestyle, to a series of expensive therapies. So coming back here, we talked about this. Clearly, I think most patients in the room are thinking probably the LDL needs to get lower. Maybe some people in the room are thinking about should this patient would clearly fit in the COMPASS trial criteria, benefit from a low dose rivaroxaban, something like that. Clearly coming down the pipeline is the idea of lowering this patient's LPO/A. My thesis number 2 for this talk is that the most impactful strategies will be those that don't just treat a single risk factor, though. The ones that fundamentally alter the pathophysiology of the disease and the totality of the patient's risk. And that starts to narrow down the list a little bit, right? Lowering a patient's LPO/A might have benefit for atherosclerotic cardiovascular disease. For example, lowering triglycerides might have some benefit. But what gets at the core problem with this patient, right? How can we treat the totality of this patient's ASCVD risk, but also the other CVD risks that this patient has, for example, heart failure? In fact, what I'm going to try to communicate in this talk is that such strategies, as we think about them, could fundamentally alter our perception of residual risk, right? Maybe our perception of what's residual changes once we think about what's actually causing the disease in this patient. So going back to this plot, I want to, while this was just published in 2020, I already think it's outdated, right? Because it talks about residual diabetes risk. There's no residual obesity risk on here. There's a variety of things that aren't on the list. I think we're past talking about just diabetes or obesity risk. We're talking about cardiometabolic risk in this patient, right? And that's the theme, I think, of the Eckel lectureship was the theme of my talk this morning. This patient's got high cardiometabolic risk, right? And really what we need to do is alter this patient's metabolic trajectory. So I'm going to show some slides I showed this morning as well, because I think it causes us to dwell a little bit on what is cardiometabolic medicine and who should benefit, who would this patient benefit most from seeing, and what would the patient benefit from taking? So I'm going to take a step back and talk about cardiometabolic medicine a little bit and just remind everyone why such a field exists, right? So this is great data on obesity. I think most people have seen this. I presented this morning as well, the BMI greater than 30, definition of obesity on the left, but severe obesity on the right. I think that's where I'm focusing the attention here because we're seeing more and more patients, right, with severe obesity, right? And this is the projections up until 2030 and just a markedly high prevalence of obesity and even severe obesity, particularly, in the Deep South and in the Midwest. I showed this morning as well. This shows kind of the proportion of patients that fit each of these categories, men and women. We can see there's a small fraction of our patients, we're getting used to it, right? Small fraction of our patients actually have normal body weight right now. A large fraction are overweight but not obese, and then a large fraction have obesity. And nowadays, a large fraction have grade 3 obesity even. An uptick particularly in women, as you can see here. We're talking about real potentially morbid obesity that's driving a lot of our disease. Now, the trends in diabetes, as I presented this morning, follow the trends in obesity. And if you look at the areas where your diabetes becoming more prevalent, it's those same areas that are having problems with obesity. In fact, diabetes trends follow very closely with the obesity trends. And this, of course, is not just a United States phenomenon. This is a global phenomenon. I showed this morning too, because I think this is important. Right? We've actually seen perhaps a slight slowing of increasing risk of diabetes in North America, maybe only projected to have a 33% increase in diabetes by 2045. But let's look around the world here. There's a projected to be a 74% increase in diabetes in Southeast Asia by 2045, 100% increase in the Middle East and North Africa. If you look, there's projected to be 63 million diabetics in North America and the Caribbean here in 2045. That actually is dwarfed by the 150 million in Southeast Asia, over 100 million in the Middle East, and so forth. So we're really dealing with a global problem of cardiometabolic disease. Yet really, when we talked about the mechanisms of residual risk, that didn't really come up as much, right? The foundation of these patients' risk. And for staggering costs associated with diabetes and obesity. I showed this morning $330 million associated with diabetes in America, $1.1 trillion attributed to cardiovascular disease. So we have to do something about this. I want to remind you that cardiometabolic disease is way more than just atherosclerotic cardiovascular disease. I think we have a short-sighted view sometimes towards our interventions if we're just considering ASCVD. Conditions that are also considered part of cardiovascular disease are sleep apnea, of course, fatty liver disease, chronic kidney disease, heart failure, particular heart failure with preserved ejection fraction, and atrial fibrillation, which is, as anyone knows who's on the wards, is epidemic, and dementia too, which is certainly one of the most costly outcomes. So this is all part of cardiometabolic disease. Can we get at the root of this rather than just trying to treat individual risk components? So I have a couple of slides here that talk about kind of the evolution of the thinking of diabetes and obesity. I didn't show this morning, but I showed the concept, right? This is the old thinking of diabetes, right? What's your A1C? Let's get your sugar down, right? And what's the new understanding of diabetes? Complicated pathophysiology, including key organs such as the liver, the adipose tissue, of course, the pancreas, skeletal muscle, etc. Understanding that it's way more complicated than just, of course, lowering someone's hemoglobin A1C. Likewise, I showed this morning too. What's the old view of obesity? We just need to watch your diet a little more carefully. Let's just have you eat a little bit less and you can lose the weight and you won't be at risk. I showed this cartoon too, right? We talk a lot of patients about what they eat, right? I think this is great. I need to eat a skinny person, right? Because you are what you eat. But we understand, of course, diabetes and obesity are both diseases unto themselves with complicated pathophysiology, right? Showed this morning as well. Obesity is a disease of the gastrointestinal tract, the adipose tissue, the brain, etc. And not just a simple kind of you need to eat more or eat less and exercise more. So we're really dealing with an understanding of cardiometabolic disease as fundamental pathophysiologic diseases that could be attacked and potentially alter the lifetime risk of a patient in terms of ASCVD and other CVDs. Okay. So why is this cardiometabolic disease its own kind of emerging area? Well, because we have clinical trials now that point to the fact that we can modulate pathways in cardiometabolic disease and lower cardiovascular events. This is just a summary of the trials that have just happened since 2015, since the FDA guidance mandating cardiovascular outcome trials for diabetes drugs for the GLP-1 receptor agonists and the SGLT2 inhibitors, showing an explosion of data, high quality outcome data showing reduction in major adverse cardiovascular events, but also heart failure, cardiovascular death and mortality in some cases, kidney events, etc. So we're seeing high quality randomized evidence that treating cardiometabolic disease can have diverse benefits. And I want to focus quite a bit on incretin-based therapies here too, right? Because we're having a paradigm change in the thinking about obesity, paradigm change in the thinking about metabolism. So now we're actually giving drugs to patients that work through the gastrointestinal, in part through the gastrointestinal tract, right? They kind of solve some of the fundamental problems that we have, in theory, in Western society, right? Make you feel a little more satiety, a little less appetite, weight loss, benefits on diabetes, benefits on many of the things that our patient that in my vignette was experiencing was driving atherosclerotic cardiovascular disease risk. And like this morning, I want to point out for those of you that haven't been paying as much attention to the obesity data, just how strong the data is for incretin-based therapy in obesity. This is the STEP clinical trial program with semaglutide, the weight loss dose of semaglutide. For those of you that haven't encountered this before or used this is a dose escalation from your standard kind of starting doses of semaglutide that you'd use for diabetes up to a weight loss dose of 2.4 milligrams weekly. And this is worth dwelling on, just how good the data is for weight loss with these therapies. So this is data over 68 weeks after your dose titration, then followed for another 52 weeks. Placebo versus weight loss dose of semaglutide here at the top. Mean 15 to 16% weight loss in these patients, right? I think we all know that that's meaningful weight loss. It can fundamentally change a patient's medical outlook. Commonly in the past, we've looked at 15% weight loss as being very meaningful weight loss. 50% of the patients in this trial experienced 15% weight loss. Actually, 32% experienced 20% weight loss, which is remarkable. So of course, this is now approved for the treatment of obesity. If those of you tried to use it, we know that there's a global shortage of the weight loss dose of semaglutide right now, because not only was there a manufacturing shortage, but everyone from Hollywood is using it now too. As you've looked at TikTok, I guess Kim Kardashian has been posting about it recently. I see some heads nodding about that. Tirzepatide is another incretin-based therapy. This is a combined GLP-1 GIP agonist that has even more potent effects. This is the SURMOUNT clinical trial program on looking at obesity. This is the so-called tirzepatide single-use pens that you escalate in dose in a similar way up to 15 milligrams weekly. It's a weekly injection. And you see even greater weight loss, right? 21% weight loss, a total weight loss with tirzepatide at 15 milligrams, compared to placebo, about 18 to 20% with tirzepatide. And we're seeing here at the bottom, something like 40% of patients achieving 25% body weight loss. Why am I talking about all this? Well, because I think this is the birth of the field of cardiometabolic medicine. This is a way of thinking about our cardiovascular patients differently. And can we treat some of the underlying problems rather than saying, well, we need to get the triglycerides down a little bit. Let's get the inflammation down a little bit. Let's do a couple other things like lower your blood pressure via pharmacotherapy. And I made this case this morning. I think this is the most important trial ongoing in my field right now, preventive cardiology and cardiometabolic medicine. This is the SELECT trial. And why is this important? This is a trial of weight loss dose of semaglutide for cardiovascular outcome reduction in non-diabetic obesity. So can we be actually targeting obesity as a target of therapy in reducing cardiovascular outcomes? 17,000 patients with established ASCVD that we randomized to semaglutide in an event, semaglutide versus placebo in an event-driven trial. My best understanding is we should hear the results of this as soon as next year, right? How did that change your thinking about that residual risk in that patient? We saw those categories and we think maybe we can treat the patient's obesity itself and lead to cardiovascular outcomes benefit. But the benefit of weight loss, of course, would be far greater than just on ASCVD. And this is the SURMOUNT multi-morbidity outcomes trial with tirzepatide that's just getting started, looking at a wider endpoint that includes heart failure. It's very likely, right, when you treat patients and get them to lose weight, their heart failure is going to get better. They're going to have less heart failure. They're probably going to have less atrial fibrillation and sleep apnea, which are all going to be secondary outcomes in these studies, along with renal endpoints. So once again, we're talking about endpoints that are much broader than just 3-point MACE. So for those of you that are on Twitter, Twitter has become a critical part of some of our communication with other scientists or tracking the literature. I put this up on Twitter just out of curiosity, because the SELECT trial that I showed you is a study that's looking at ASCVD, but probably these therapies are going to have much wider ranging benefits than just on ASCVD. So I asked the audience here, for a powerful weight loss drug, what outcome would be expected to improve the most? Actually, the number one answer was sleep apnea, and heart failure and atrial fibrillation followed very closely after that with ASCVD. This makes sense to me. I think this is what many of us are expecting, to potentially have drugs that could alter multiple components of patients' risk, and multiple of them expensive things that lead to hospitalizations and other therapies in our practice. Okay, so let's step back and say, how does the physician training, the traditional roles, our roles as endocrinologists, as internists, as cardiologists, affect our approach to residual risk, specifically cardiometabolic risk? Because, like I said, I think everyone in the audience would have a slightly different approach to this patient if I showed this up here to people at different institutions, different specialists. Patient's going to get treated differently. Is that right or is that wrong? Certainly, when it comes to cardiometabolic risk, I showed this data in a different way this morning as well. This is data dating up to June of 2020 using the National Prescription Audit. I'm going to pick on cardiologists here. I'm a cardiologist, so I can do that. SGLT2 inhibitors and GLP-1 receptor agonists, as I mentioned, reduce cardiovascular events and in some trials, even cardiovascular all-cause mortality. But cardiologists have been extremely slow in the uptake of these therapies, right? While there's been an uptick recently, just 1.5% of total SGLT2 inhibitor prescriptions and just 0.4% of GLP-1 receptor agonist prescriptions are by cardiologists, even though these are cardiovascular risk-reducing therapies, right? Particularly when it comes to drugs like GLP-1 receptor agonists really are not used much by cardiologists. I showed this data this morning. I think this is great for the mixed group of internists we have here. This is data from Neha Pagadapati at Duke, which I thought was a great study that she did in just a small number of practitioners, but I think it generalized to the entirety of the hospital here. What are the perceived barriers to prescribing cardiometabolic drugs amongst endocrinologists, primary care doctors, or cardiology providers, and how do those differ? So here in orange is endocrinology, blue is primary care, and green is cardiology. I think you see different answers here. So, for example, let's ask a cardiologist, why would you maybe not prescribe a GLP-1 receptor agonist or a SGLT2 inhibitor? The bottom here, this won't surprise you. It says, well, it's not my responsibility to prescribe diabetes medications as a cardiologist. Why would I treat diabetes? I don't want to introduce confusion into an existing diabetes care plan. Someone else is taking care of that part of it. It's difficult to effectively communicate with PCPs and endocrinologists, which I love because that shouldn't be a barrier, but it is. And I don't know enough about these medications, right? It's a very different profile when you look at primary care doctors and endocrinologists who are largely saying, well, these are just expensive drugs. And I think we can do this much cheaper. Prior authorization is burdensome. And I just don't know if we really need to go to these drugs necessarily for this particular patient when we have lots of other options. So very different viewpoints, right? Depending on who you saw. If you were Joseph in the case here, right? If you saw an endocrinologist or you saw a cardiologist, or maybe you saw your primary care doctor. I showed this morning too. This is just picking on the cardiologist again, who basically said at the time of this study, just didn't have enough knowledge about the way that these cardiometabolic drugs work or their side effects to use them. So we really need to do more education to all of our providers, particularly cardiologists. So Bob Eckel and I have been thinking about solutions to kind of this problem for some time. I'm going to present in abbreviated form some of the same things I presented this morning about how do we improve cardiometabolic care. I'm going to focus particularly on cardiologists, but I think this applies to all internists, right? How do we approach Joseph, the patient, in a more thoughtful way? And how in the future are we going to have the right workforce to take care of patients like this? And the solutions kind of in temporal order, really, first of all, to update guidelines, make this guideline-based care. Second one I'm going to present, to have new clinic structures, what I'm going to call a cardiometabolic clinic, where we can get endocrinologists and cardiologists together, or maybe new specialists together that can take care of all the issues that this patient would have, rather than shuttling this patient to different specialists. In the future, thinking about, do we need a new even specialty in cardiometabolic medicine? Because this is the primary problem that drives healthcare spending. And could we have a specialist who takes this on? So for those of you who don't know these guidelines, I'd like to present these. The cardiologists are slowly catching up to the endocrinologists in terms of getting this out in our cardiology guidelines. This is the treatment algorithm for patients with type 2 diabetes and ASCVD, or high or very high risk of ASCVD, who are drug naive. I always like to say to my cardiology colleagues and my fellows, we see these patients all the time, right? They come in, they're admitted to the hospital with a coronary syndrome. We get an A1C and it's elevated. They hadn't had one checked before, and we need to manage the patient. And it says the patient has ASCVD or is high risk of ASCVD, and the drug naive, the first therapy should be an SGLT2 inhibitor or a GLP-1 receptor agonist, right? Getting those cardiovascular risk-reducing medications up front. And only if they're not high risk, do you go down a pathway with metformin. And if you look here, I would argue that nearly all the patients in a cardiology practice are high or very high risk, right? They either have established ASCVD, they have target end organ damage, let's say left ventricular hypertrophy, or they have 3 or more major risk factors, with those risk factors being age, hypertension, dyslipidemia, smoking, or obesity. So really, I think we're at a point where in a cardiometabolic practice, really all the patients should be upfront, starting with an SGLT2 inhibitor or a GLP-1 receptor agonist. And I'll talk about, to the cardiologist tomorrow, I'll be talking about calcium scoring and CT imaging. And it says here, for a patient with diabetes who wouldn't necessarily otherwise be at high risk, you can consider a CT scan to look to see if they have a high burden of subclinical disease. If they have a high burden of subclinical disease, don't wait till their secondary prevention. Start in primary prevention, treating them with cardiovascular risk reducing therapies. And a reminder in these guidelines that metformin gets only a 2A recommendation because there really isn't as strong of outcome data with metformin as there is for what I'm going to call cardiometabolic drugs. For the cardiologist, I'll just mention that the ACC says something very similar. What I'll say here, not only does it mention starting an SGLT2 inhibitor or GLP-1 receptor agonist first, but it says as you progress down the pathway, you can start the opposite therapy. You can do combination therapy with both drugs when a patient needs risk reducing or A1C reduction. So we have some great data. We have some great new therapies. So why aren't we achieving better real world results? Right? I already showed you that only 1% of all prescriptions come from cardiologists. Clearly, a lot of patients aren't benefiting from these. I showed this morning too, but I hope this resonates with people in the medicine audience here. Let's go through kind of the patient's journey, right? We talk about the patient who is admitted with a coronary syndrome. Maybe wasn't on much therapy at all. After that, gets a couple stents. They follow up with a cardiologist, where the emphasis is on dual antiplatelet therapy and other things like that. Maybe getting the patient to cardiac rehab. Maybe the patient does go over to endocrinology, where there's a ton that needs to be done for this patient who doesn't even have the self-efficacy and carb counting and knowledge of diabetes, where a lot needs to be done with the endocrinologist. Patient goes back to the primary care doctor who says, I've got other issues to deal with. The cardiologist and the endocrinologist are kind of dealing with the cardiometabolic disease. Patient goes back to the cardiologist who says, well, I think the endocrinologist will start you on the SGLT2 inhibitor or GLP-1 receptor agonist. I won't get involved with that. The endocrinologist figures the cardiologist might have been dealing with that. And lo and behold, as the patient goes back and forth, therapeutic inertia sits in, right? And sometimes it happens that despite our best intentions, patients don't get on appropriate therapy, right? Not only that, but the patient says, who is in charge of my disease? And in fact, thinks of it as different diseases, right? Thinks of this as, well, I've got diabetes and I've got cardiovascular disease and I've got hypertension. I've got 3 separate specialists for that. And has never really put it together that I've got cardiometabolic disease. So our solution, our proposed solution for that is what we call, and what many are calling, the cardiometabolic clinic model. Starting clinics where bringing endocrinologists and cardiologists together, or even an internist with a special interest in this area, to try to treat several cardiometabolic diseases at the same time, to improve their outcomes, to increase the efficiency of care, and hopefully reduce cost. And also just give the patient the sense of who's treating, who's in charge of my disease. So I want to point to, and I showed this this morning as well, because I think Mikhail Kosparod at Mid-America Heart Institute has done the best job on starting this model. He's actually started a cardiometabolic center alliance, which Hopkins is probably going to be joining, but many centers have joined a network of cardiometabolic centers of excellence that are trying to communicate best practices and things on how to treat and start a clinic in a healthcare system. And Dr. Kosparod showed this is just some early data from his first 130 patients in his cardiometabolic clinic versus patients that went to standard of care. They might have been to a specialist. They might have just been treated by their primary care doctor, had greater weight loss, better change in their A1C, better improvement in blood pressure, and better reduction in their LDL cholesterol. And not surprisingly, more use of, in this case, SGLT2 inhibitors and GLP-1 receptor agonists, as well as kind of intensification of existing statin therapy and the like. So maybe just, you can imagine, if one randomized patient to a cardiometabolic clinic versus standard of care, you might get better outcomes just based on where the patient goes. So we started our own cardiometabolic clinic at Johns Hopkins, and we've been taking referrals from inpatients, from other cardiologists, but other internists, And I was mentioning this morning, it surprised you to find out that nowadays about 60% of our referrals are actually for obesity or actually for weight loss. Only a minority actually, even though we were thinking about this as diabetes at first, which is why the term cardiometabolic medicine is really more appropriate than even just diabetes, because a lot of patients are coming in, for example, they have their AFib ablation and their BMI is 40 or they have HFpEF, and we're helping out with those patients. Okay, so the question now becomes, do we have the appropriate training? Are we training the patients the right way to staff such a clinic? So we put this poll up on acc.org a while back, which is the American College of Cardiology. Do we need a pathway for clinical training in cardiometabolic medicine? Or kind of the alternative was, or you feel like you're getting what you need from your training? And maybe not surprisingly, only 15% said the current model is adequate, and 85% said some new model is needed in terms of getting training in cardiometabolic medicine. I mentioned this morning that at Hopkins, when I was there, great training. Did I get any training in obesity? No. Did I get any formal training in lifestyle therapy? Not really. Did we recognize that cardiometabolic disease was driving much of our patients' care? Yes, but we weren't really attacking the problem at its roots. So a plug for what Bob Beckel and I are doing is we're really trying to launch this idea of starting a fellowship training program in cardiometabolic medicine that an internist could then attend, an interested cardiologist or endocrinologist could attend this fellowship and get advanced training in cardiometabolic medicine. We've been trying to get multiple sponsors from the pharmaceutical industry to support this initiative. And I think we've had some early success, but this has been a process to try to get a sustained cardiometabolic medicine training program at multiple institutions that have expertise in this, and training the new leaders. Because I said this morning, in our medical students and our residents don't really see the field until they can see people training the field to become cardiometabolic specialists. Say that's what I want to be. So when Bob and I envisioned cardiometabolic medicine, we came up with this Venn diagram to figure out what it is, but also what it's not, right? Because it can't encapsulate all of cardiology, certainly can't encapsulate all of endocrinology, and certainly not all of internal medicine. So I think cardiometabolic medicine is the nexus of these things here. So what we're picturing for a fellowship training or a career pathway in cardiometabolic medicine, it wouldn't necessarily include advanced training in electrophysiology or interventional cardiology or advanced heart failure. Wouldn't have the same emphasis on thyroid, reproductive, and bone. Wouldn't have as much emphasis on primary care aspects of internal medicine, including musculoskeletal, screening, or pain medicine. But would certainly have in its wheelhouse obesity, type 2 diabetes, hypertension, lipids, lifestyle, smoking, rehabilitation, and basics of cardiovascular testing. So this was a proposed training plan that we put together of what the skill set that this patient or this physician would need to have. Certainly a strong endocrinology background, certainly a strong cardiology background with some basics in cardiovascular testing, and certainly lots of emphasis that we learned from our internal medicine colleagues about lifestyle. So Bob and I envisioned that someday maybe if we start a fellowship and we train some people, someday maybe there could even be a pathway to a new subspecialty track in internal medicine called cardiometabolic medicine. And if you're interested, we've written about this most recently in the American Journal of Medicine. We put out a call, or at least a thought exercise, for a new subspecialty training track in internal medicine in cardiometabolic medicine. Why? So that patients, like I showed you at the beginning, have a place where to go and get a systematic approach to reducing cardiovascular disease. So this is an idea that we'd like to aspire to over maybe a decade. Okay, so how will we define residual risk in 10 years? I think this is sort of an interesting question because it forces you to think about kind of what the core therapies would be. So once again, get back to this diagram, where it showed patients at high risk for ASCVD, despite contemporary evidence-based therapies as sort of vague, interpreted now sort of as statins, and you go on to these other individual risk factors. But I think the future holds something more fundamental here. I think here we're talking about these evidence-based therapies. I think we're talking about fundamentally getting at the pathophysiology of most of ASCVD risk, and that's cardiometabolic risk. So going back here, instead of, I'm not crazy about this diagram, as you can tell, just because it separates out a lot of things that could be actually all altered by the same pathophysiology. An idea of giving an antibody to reduce anti-inflammatory, great. I'm very interested in that science. I just don't know if that's the answer, giving anti-IL-6 antibodies to treat atherosclerotic cardiovascular disease. Okay, So let's finish with a different case. Hopefully this hits home a little bit. And it's certainly someone that you would see. Let's consider this 59-year-old male, stage 2 obesity, advanced subclinical atherosclerosis, hypertension, obstructive sleep apnea, and paroxysmal atrial fibrillation, has prediabetes, left ventricular hypertrophy, and grade 2 diastolic dysfunction on an Eckel. But overall, except for some mild shortness of breath, feels okay. Patient works from home, very sedentary, takes a lisinopril, atorvastatin, and some sleep aids for some insomnia, has a BMI of 39, blood pressure of 146/88, some trace lower extremity edema. A1C is 5.9, LDL is 99, creatinine is 0.8. And the question I want you to consider here, or at least in terms of categories, what drug class or what approach is most likely to make the biggest and most fundamental impact on this patient's lifetime disability, morbidity, and mortality? And hopefully, if you agree with me, I think it's taking a cardiometabolic approach, right? We need to get the blood pressure down. Certainly, we need to address, probably the patient needs to be anticoagulated for atrial fibrillation, et cetera. What's fundamentally going to change this patient's outlook? And I would argue a cardiometabolic approach, and most likely, once we have the data, approach probably for weight loss. Okay, so let me summarize what I said by this slide, saying that residual risk, I think, is an evolving concept, right? Certainly, it's residual to the statin. It also needs to be thought of residual to probably something more fundamental than that, too. I think it's more residual to lifestyle and potentially approach to cardiometabolic disease. For those of you that are interested in the field, preventive cardiology is booming now with an array of new tools, right? Once upon a time, someone would consider a preventive cardiologist sort of a statin doctor, right? Nowadays, there's so many therapies that we have. It's becoming extremely interesting as a field. But I think cardiometabolic disease is the fundamental epidemic and is the driver of much modern residual risk. And I think, in summary, we need to rethink the future of cardiometabolic medicine training and care delivery to try to do better than we're doing right now. And then education, too. And I think this starts with cardiometabolic clinics and thinking about cardiometabolic medicine in general, and then potentially a cardiometabolic specialty that we can encourage our trainees to go in to try to get at the core epidemic of our time. So thank you very much. And thanks, Dr. Eckel, for this opportunity.
Throw things open to questions from our audience. Michael, we're waiting for a couple questions. One thing you talked a lot about, the reduction in obesity being one of the primary drivers of reduction in cardiometabolic disease.
Yeah.
Where does bariatric surgery fit into this paradigm now that we have so many new medications?
It's a good point. Before I forthright you, I'm not an obesity specialist. I've sort of arrived at this from cardiology, which is what I think many of us need to do. But it certainly plays a key role. However, I will say that the results we're starting to get with the newest therapies start to rival that of bypass. Sometimes we need to go on these therapies to get a patient to lose enough weight to be eligible for bypass, gastric bypass. So I think it's one tool in the toolbox. But I think the future, of course, is not going to be surgical disease. The future will be a metabolic treatment.
Thanks, Dr. Blaha. Your slides are beautiful and laid things out nicely. One of the comments that you made that I love that I've never heard anybody say is that physicians will prescribe, are pretty willing to prescribe one expensive drug, maybe two, but not more. It is kind of odd because from a utilitarian standpoint, that really doesn't make sense, right? We should do some analysis of the ICER and figure out whether it's crossed some threshold and do everything above and nothing below. But getting that kind of data is also really challenging. So I was kind of listening for you to say, for these patients, how you would go about sorting through, start with one, do number two, then three. I think you got there maybe with GLP-1 receptor agonists, but I don't know. And it depends obviously on the patient, but maybe could you take us through how you do that in clinic a little bit more frequently? Because obviously your patient, even if you want to do 5 drugs, your patients may say no. So if you got to pick one, where do you start?
That's a great question. And we need a lot more comparative. It's going to take a long time to have it. A lot more comparative effectiveness data and more cost effectiveness data. Unfortunately, a lot of these drugs still don't meet the cost effectiveness thresholds that we'd like to see, unfortunately. Eventually they'll become generic. Yeah, you're right. Instead of as much of a solution, I more painted the problem, right? Which is what a good speaker does, right? And then has the audience figure out the answer. But the problem is our guidelines don't have any component of prioritization in them, right? I don't think many guidelines do. I think part of the reason is we don't have the data or the value kind of structure to do that. But I did make the case that I think that metabolic disease should be at the core of this. I don't want to plug GLP-1s in particular, but I think that is our best option right now. We'll have more options eventually, but I do think that continuing to treat, I'm open to the idea, but for example, there's been a lot of work on inflammation. Should we be treating inflammation? Gosh, a lot of the inflammation is just secondary to metabolic disease, right? Triglyceride lowering, I'm interested, but maybe it's not going to work so well. And maybe that's because we're not getting at the underlying pathophysiology. So I am making a case a little bit that these patients, we shouldn't be telling them you've got the problem list has 6 things on it. It does have 6 things on it, but there's some core thing that, Bob described a long time ago, the metabolic syndrome that ties these together. And I think when a patient understands that, and we have a treatment maybe that gets at that, I think we can make a bigger difference. And the ICER likely for these particular drugs, I'll make the case, underestimates the benefit because we look at MACE, but we don't look at sleep apnea. We don't look at even musculoskeletal outcomes and things like that. So I think that where it's relatively easy to give you an ICER for LDL lowering, because I know exactly what it does. LPA lowering, I probably could calculate that out. I think it's very hard here. I think we're underestimating the potential benefit of these drugs. I think the marketplace is showing that right now.
Question from a future cardiology fellow here.
I've got a couple of questions from the chat here. One is, how do you see the gut microbiome impacting cardiometabolic risk?
It's a good question. I'm not a gut microbiome expert. I've kind of heard a few of the companies that are working in this area. It's clearly a part of metabolism, and maybe, I'm not sure it'll be through pharmacotherapy or just better diet. I mean, I think modulating the gut microbiome makes sense, and I've seen data that shows that modulating the gut microbiome can make a pretty significant difference in metabolic parameters. I'm not sure where it's going to fit in. I'm interested in that area. Though. I think it's worth pursuing.
We've got a plug for adding pulmonology to your triangle of internal medicine, endocrinology, and cardiology, as a lot of our new hypoxemic diagnoses are related to obesity. So a plug for that.
Yep.
And then our last question here is from one of our medical students saying that they've seen semaglutide prescribed a lot for weight gain related to antipsychotic use and the role that pharmacotherapy plays in obesity development. Do you think that semaglutide has the same efficacy for those folks?
Yeah, that's a good question. I think we need to hopefully we can get to an area where we can do more precision cardiometabolic medicine too, that we realize that this obesity phenotype is better treated with a GLP-1, for example, maybe this one is better treated with another strategy. That sounds like a complicated one, medically influenced obesity. I think it's very likely to work. I'd be curious for my colleagues' take on that, but very, very likely to work. And I would never mean to suggest that lifestyle isn't first. Of course, lifestyle is first, but we also need to recognize that the data on lifestyle is pretty darn poor, right? It's pretty poor. And that's part of this recognition that obesity is a disease. So yeah, I think that there's a potential value of this in a lot of different types, let's say, of obesity. So I'd be very interested in studying it there.
Hi, I'm Prerna. I'm one of the cardiology fellows. Really excellent presentation, really interesting. I have a couple of questions. One is let's say you have a 6-foot patient who's 300 pounds. I just calculated the BMI that comes out to 40, which is pretty severe obesity. A 10 to 15% weight loss. They're still pretty obese. Is the goal in the cardiometabolic health space to get to kind of normal weight, or do you see kind of enough improvement with these 10 to 15% weight loss, which has been demonstrated at least for diabetes remission and such, that kind of weight loss is enough?
I think the more the better. I think the new drugs can even get 20% or more. But clearly, the good thing is even at 5% weight loss, you can start to see benefits on metabolic parameters, right?
Yeah.
And then the more, hopefully, the better. It'd be aspirational to say that a patient could return to normal weight. I think that's probably a little, I wouldn't go so far. But yeah, I think the goal should be substantial weight loss. And I think we don't have as much data on the long-term benefit of these drugs, but I think that the curves are likely to continue to diverge. Now, a complicated question comes up is if you need to be on these medications for life. That's a complicated one. But I think what I tell patients, some weight loss is, or even the smallest amount of weight loss is good. More is better. So that's the way I approach. So if I was approaching a patient in clinic, yeah, I'd be setting a pretty ambitious goal of 15 to 25% weight loss.
Yeah. And I think that kind of answered both of my questions. Thank you.
Thanks. Josh.
Great talk. So I'm just a simple infectious disease doctor, and so a lot of these words I didn't understand. But and I very much appreciate the model of converging specialties. I'm curious though. I noted in the triangle of PCP, cardiologist, and endocrinologist, it was a closed circuit. And I'm wondering if you could talk a little bit, because this is an epidemic, and we've dealt with those before, the role for such a training to expand into social and structural determinants of health, and the role for physicians and people within the medicalized system to work with public health to actually control the epidemic upstream, as opposed to more meds.
Yeah, clearly. Yeah. I always feel when I give these talks, I do feel a little uncomfortable sometimes. So I feel like I'm talking about medicines a lot, when of course the solutions ultimately have to go even more upstream to, the way we live our lives, our culture, you know what I mean, and structural factors. And physicians, and clearly I could see a future for a cardiometabolic specialty, maybe getting training in public health or working with public health folks on these questions. Because clearly the answer, I mean, we're not going to be, the answer isn't medicines in perpetuity. We have to solve this at a root cause. So yeah, I don't ever mean to imply that the answer is always medicines, although in some ways, we've seen the limitations of what we've been able to achieve with structural change, with lifestyle therapy. But clearly that's a huge part of it. And you're right, when you talk about an epidemic, right, the solution to an epidemic isn't always medicine, right? It's changing the way you live. It's changing the way we interact with each other. Very challenging, but aspirational once again. Starts the food industry, starts with, let me go down the list, legislation, et cetera. But great points. I have a public health background, so I'm very appreciative of that. I don't know the answers, but very important.
One question here.
The question I have is, how do you get insurance company to cover these obesity meds? I absolutely agree. As a diabetologist, that's which way I would go first, but give us some tricks on that one.
Yeah, this is a great question. It's changing before our eyes, unfortunately. I've seen, we're seeing a pullback a little bit of coverage of these. I think it's a more logical plan is put forward. I was getting a lot more these drugs covered at first than I am now. In fact, I don't know if you guys have seen one. I got a patient the other day that requested step therapy through orlistat and other drugs, that are just have meager, if any, benefit. And of course, we're not going to walk through those pathways to get to these drugs. So this is an evolving area, and that's why the outcome study is so important. I think the answer is the outcome study, the outcome studies I mentioned. Once we've demonstrated that there's cardiovascular benefit of this, and we can prove that the sleep apnea and the heart failure go down, I think that when we heard about the ICER earlier, the cost effectiveness ratio, that case can be made. And I think these are drugs that are likely to become cost effective, as opposed to some of the other ones on the list. That's another kind of part of what I'm getting at. Some of these other drugs I think are unlikely to be fundamentally important enough to be cost effective, but these I think are. So I think we got to really advocate for our patients here. But this is tricky because, as you know, there's a shortage of these now because patients are buying these on the open market even to use them, because that tells you something about the demand and what people's perceived effectiveness ratio is. But great point. Medicare is not paying for them at all.
And I think we'll give Dr. Eckel the last question.
Well, Mike, thanks very much for being here. I'm really honored by your presence. You're a great colleague and friend, so it's been great working with you, and I hope that continues. The only comment I might make is the question related to bariatric surgery. There's clearly no randomized controlled trials that shown benefit. There's lots of studies that have claimed to be randomized, but they're really not. There's a lot of selection bias that goes into those trials. But weight loss, the expected weight loss at nadir and sustains is in the 22 to 25% range. But the time is absolutely correct right now for comparing liraglutide or semaglutide at high dose with bariatric surgery in terms of outcomes. Now, who would fund that study? I think that has to come from the NIH, and I don't see a drug company sponsoring such a study. Somebody's going to be a loser there.
Right.
But ultimately, the data seem to suggest that cancer is reduced with bariatric surgery, cardiovascular disease events are reduced, all the metabolic outcomes that you alluded to here are benefited by that operation. And now the bariatric surgery community, the academic aspects of it shows the cost benefit long term. I'm not promoting surgery, but now I think with the pharmacological interventions that you pointed to today, we have the need for a randomized controlled trial comparing a comparator, meaning a drug, with the operation to see what the outcomes are.
Yeah.
Thank you again.
Great point.
Any last thoughts on that, Mike?
No, I don't think I have any other thoughts, although I just, another plug for a trial design. I'd like to see a trial design just randomizing patients to different care models, right? We talk about these patients could be treated very different ways. Just randomizing them to a dedicated cardiometabolic specialist, whether that be an endocrinologist, cardiologist, or a new specialist, versus standard of care is likely to be extremely cost savings potentially. That's all.
Great. Well, it's 1 o'clock, so we'll get wrapped up. But thank you very much, Dr. Blaha.